All right, everyone. So let us begin the session. I'm sorry I got late by 10 minutes due to the technical issues. So I'm Dr. Simran Kaur. I'm a radiology resident and I'm an ECFMG certified physician. I'm done with USMD Step 1 and Step 2 CK. Now, we would be discussing during this high yield series all the important concepts that would help you to, ace the NEET PG. And definitely they would help you for other exams also. But right now our focus is NEET PG 2023. Now, I am here to talk about, first of all, the resources that you have to follow. Although the time is really less, but still I would say the resources that you need to follow now is first aid for your family. If you have this book is a gem. So at least at the end, whatever high yield points they have given, you can just start reading them. And there are a few tables given in first aid which are very, very high yield, so you can follow those also. And for PSM, you can go ahead with the new programs, so you can read about them. And the most important is the previous year's important topics. So I won't say previous year questions. Why? Because you don't have to do the rote learning, not just talking about the questions being asked and learning the answers. In fact, you have to go ahead with the topics that were being asked repeatedly. So you write down and make a list of the topics and master those topics. That is how you want to ace NEET PG. Now, for example, so in today's class, it's going to be a very short class because here I'm going to tell you first of all the orientation, okay, how we are going to go ahead. All right. So supposing in one of our exam, it was being asked the first line drugs for osteoporosis. All right. So supposing you come across this question, you don't just have to directly jump onto the treatment of osteoporosis, because if you do so, you would be missing out very, very important points. And if you don't have thorough knowledge about osteoporosis, so supposing in the subsequent exam, you're now being asked about osteoporosis, something else, right? How do you diagnose it? So you won't be able to answer that. So let us move and let us try to understand the basic concepts regarding osteoporosis, and then we'll subsequently get back to the first line drug for osteoporosis. All right, let me read your comments. All right. So first of all, we would be talking about osteoporosis. So what is osteoporosis basically? So whenever you think about osteoporosis, the main kind of history that comes to your mind is a postmenopausal female coming to you with some lower backache, and when you examine, there is point tenderness. All right, or there is some kind of fragility fracture at uncommon locations that is not actually related to major trauma. Now, let us try to understand what is osteoporosis. Osteoporosis means the bones have become weak. So, this is the most lame meaning of osteoporosis. Bone strength is reduced. Bone strength is reduced. All right. Now, when you talk about the bone strength here, if you go to the conventional definition of osteoporosis, then you talk about the bone mineral density. So osteoporosis means reduction in the bone mineral density, as I've written here, right? Bone mineral density, if it is reduced, that means there is going to be decrease in the strength of the bone. And if strength of the bone is reduced, obviously the patient would be at increased risk of fractures. Now, the next question is, how would you know that the bone mineral density is reduced? How would you get to know if bone mineral density is reduced? Anyone? So, how would you get to know if bone mineral density is reduced? So, the answer here is, first of all, you should know that what is bone mineral density? By bone mineral density, you mean to say that you are measuring the amount of calcium and other minerals in a particular area for bone, right? Bone mineral density is being measured by something known as a DEXA scan. Now, DEXA scan stands for dual energy X-ray absorptiometry. All right. Now, another point. There are two terms that you should be well versed with before beginning this. So you always compare two terms, that is osteoporosis versus osteopenia. Osteopenia. Now, what is the difference between both of them? See, osteoporosis means reduction in the bone mineral density. Osteopenia also means reduction in the bone mineral density. Then what is the difference between these two? The difference is that osteoporosis, there occurs reduction in the bone mineral density and there is a subsequent risk of fractures also. So increased risk of fractures too. So that means the bone has become so weak that there is substantial risk of fractures also. When you talk about osteopenia, osteopenia means reduction in the bone mineral density, but here you're not worried about the risk of fractures. Okay, so the risk of fractures is not as great as you see in case of osteoporosis. Just a second. All right. Now we move on to the next point. Osteoporosis has been divided. You divide osteoporosis as primary osteoporosis and secondary osteoporosis. Primary osteoporosis have been further divided into two subtypes. Number one is postmenopausal, and number two is senile osteoporosis. The postmenopausal osteoporosis is also known as the type 1 osteoporosis, and senile is type 2. All right. Now, as the name itself is suggesting postmenopausal. Postmenopausal means after menopause, the type of osteoporosis that is occurring, that is postmenopausal. Senile is related to old age. So the reduction in the bone mineral density and subsequent reduction in the bone strength that occurs in the elderly, that is senile osteoporosis. When you talk about secondary means due to something else, like due to some drugs or due to some medical conditions like hyperthyroidism, hyperparathyroidism, hypercortisolism. All right. So now let us try to understand these things in detail. Now what I have written here is the postmenopausal, that is type 1 osteoporosis. That means after menopause, right? Now, why do you think postmenopausal osteoporosis is very common? Why do you expect a postmenopausal female to have osteoporosis? What is the reason for that? Yes. Anyone? Why do you expect a postmenopausal female to have osteoporosis? What is the reason? To try to understand this concept, what happens is when menopause occurs, menopause means there is no menstruation for at least 12 months. All right, 1 year there occurs no the menstruation. Now, when menopause occurs, the levels of estrogen, they are reduced. The levels of estrogen, they are reduced. All right. Now, for this, you need to understand what normally estrogen is doing. So, normally estrogen leads to what? Estrogen stimulates the osteoblasts, and normally estrogen induces the apoptosis of osteoclast. Now, this concept you would be only able to understand if you know what are osteoblast and osteoclast. All right. So there are two types of cells that we are discussing here. Number one, osteoblast, and number two, osteoclast. So can anyone tell me what is the difference between osteoblast and osteoclast? Yeah. Anyone? See, osteoblast, they are the bone forming cells. Osteoclast are the bone eating cells or bone resorbing cells. First of all, know this concept, okay? So if osteoclastic activity is increased, obviously the bones are going to be eaten away, so they are going to become more weak. But now, normally what estrogen does is it stimulates the osteoblast, bone formation is being induced, whereas it is inducing the apoptosis of osteoclast, all right? Now, but what happens in menopause? The estrogen levels are reduced. So if estrogen levels are reduced in menopause, that means the opposite is going to happen. Right? Estrogen, which was previously stimulating osteoblast and inhibiting osteoclast, now estrogen is not there in sufficient amounts. So what happens is osteoblastic activity reduced and there is no one to inhibit osteoclast, so osteoclastic activity is increased. So more bone resorption takes place. All right. Moving on to the next point. So this is what I have written, that normally estrogen stimulates the osteoblast and causes apoptosis of the osteoclast. And osteoblasts are the bone forming cells and osteoclasts are the bone eating cells. All right. Now, so there are few points that I mentioned in Robbins. Apart from this concept that estrogen levels are reduced, that leads to decreased stimulation of osteoblast and increased activation of osteoclast. There are other points given in Robbins. For example, Robbins says that during menopause and after menopause, what happens? The levels of interleukin 1, they are increased. Now, when you read immuno, interleukin 1, interleukin 6, TNF alpha, these are all inflammatory cytokines, all right? And interleukin 1 is also known as the osteoclast activating factor. So that means if the levels of interleukin 1 are increased, the osteoclastic activity is going to increase and ultimately bone resorption will also increase. And one more thing is mentioned in Robbins. They say that activity of rank and rank ligand also increases. Now, let us try to understand this concept of rank and rank ligand. Yes. So we have osteoblast, then we have osteoclast, on the osteoblast we have rank ligand, and on the osteoclast we have rank. Now, what is the importance here? The importance is that rank ligand interaction with the rank is very, very important. So if there is binding or interaction of rank ligand with rank, what happens is this induces the activation and differentiation. So write down the differentiation and activation of osteoclasts. So the more the interaction between the rank ligand and the rank, the more will be the activation of the osteoclast, more will be the bone resorption. All right. So this is the interaction between the rank ligand and the rank. This is the importance. Now what Robbins says is that after menopause, the activity of the rank and the rank ligand is also increased. That means more activation and differentiation of osteoclast is going to take place during menopause. All right. Moving on to the next point. Now, then they say that there is something known as senile osteoporosis. Before this point, I want to tell you one more thing here. Now, since we discussed that this interaction between the rank and the rank ligand is very important for the differentiation and activation of osteoclast, but this abnormal or excessive activation of osteoclast also has to be stopped or prevented. So, how is it being done? Can anyone tell me the name of that substance or the molecule that actually prevents the excessive interaction between the rank ligand and rank? Yeah, anyone? So the answer is osteoprotegerin. There is a substance known as osteoprotegerin, OPG. All right. So what OPG does is, from where is OPG coming? This is being secreted by the osteoblast. This is being secreted by the osteoblast, and osteoprotein, it actually inhibits the interaction between the rank ligand and rank. All right. So this concept would be made useful when I talk about the treatment of osteoporosis. So I'll come back to this. Moving on to the next point. I'm talking about the second variety of osteoporosis, primary osteoporosis, that is senile osteoporosis. Senile, as I already told you, that is like related to old age, right? So age-related decline in the bone mineral density or age-related decline in the bone strength, that is senile osteoporosis. Now what happens is with the increasing age, the activity of osteoblast, it is reduced. Okay, that is how there could be senile osteoporosis in the elderly. Moving on to the secondary osteoporosis. Now, secondary osteoporosis, as I already told you, this occurs in context to something else, due to something else. For example, due to some drugs or due to some medical condition. So let us try to have a look at the drugs that could induce the secondary osteoporosis. So you should know that which drugs they could lead to osteoporosis. Number one, the long-term treatment with the steroids. Okay, so I'll give you a brief history. Let me see who can diagnose the condition. So a middle-aged female comes to the OPD with a pain in the small joints of hands and feet. She's having neck pain also. In the morning, she feels her body to be stiff. And once she starts doing the activities, the stiffness is reduced. The stiffness is reduced. And she also complains of reduced hand grip. So look at this typical history. So what do you expect here? Exactly. So I can see the comments here. So a lot of you have answered it correctly. This is rheumatoid arthritis. This is a typical history of a patient having rheumatoid arthritis, which is an inflammatory destructive arthritis that occurs most commonly in females, and it affects the small joints more. All right. Now, when you talk about the management of rheumatoid arthritis, so we usually prefer DMARDs as the first line management, like methotrexate. All right. Then we have hydroxychloroquine. Then we have sulfasalazine also. So there are different DMARDs that you can prefer for rheumatoid arthritis. But for the acute flares of rheumatoid arthritis, supposing someone is coming to your OPD with a lot of swollen joints of hand and feet, and it is very painful. So for the acute onset and the flare of rheumatoid arthritis, you would be preferring the short-term steroid course. All right, and you know that steroids are very potent anti-inflammatory agents, and they work like magic. So what happens is a lot of cases when you prescribe steroids to a patient having rheumatoid arthritis acute flare, they feel very fine. They see that the swelling has been gone. So they would feel that this is the best drug for them, and they never come back to the OPD and they continue taking the steroids, right? So supposing this type of patient is on long-term steroids, what is going to happen ultimately? So your take-home message here is, number one, read the side effects of steroids. Okay, so you have to read today the side effect of steroids. They are very, very important. So one of that is that steroids make the bones very weak. All right, steroids make the bones very weak. So what is the reason for that? Long-term steroid therapy, what does it do? It leads to rank ligand mediated activation of osteoclast. That means that they are going to lead to more activation of osteoclast, and they are going to lead to the apoptosis of osteoblast. I hope you know the meaning of apoptosis. What is apoptosis? Now, someone is asking diagnosis of RA, morning stiffness should be at least, see, it should be 1 hour, 1 hour of morning stiffness. But if you practically see these type of females, the main complaint is not morning stiffness. The main complaint is the pain in the small joints of hand and feet. Then they have the involvement of the cervical spine. So they have neck pain also. All right. Yeah. So what is apoptosis? Yeah, exactly. Apoptosis means programmed cell death. All right. So what happens is that there are situations where apoptosis occurs physiologically also, and there are situations where apoptosis occurs pathologically. Unlike necrosis, necrosis is always pathological. So apoptosis means there is cell death occurring of the osteoblast that is induced here by the steroid treatment, which if being taken for a long time. All right. And second, the drug that is being preferred, the drug that could lead to osteoporosis is heparin. Now, heparin is what? What is heparin? Heparin is an anticoagulant, parenteral anticoagulant. All right, remember this point. Moving on to the next drug, we have levothyroxine. So, supposing a patient is having hypothyroidism, you put that patient on levothyroxine, and that could also induce the osteoporosis. Then anticonvulsants, and lastly the proton pump inhibitors. So practically people who feel that they have GERD, that is reflux, the acid reflux, or they feel that they have a lot of acidity, so they keep on taking proton pump inhibitors. But now new studies are coming up that proton pump inhibitors are not that safe as they were considered to be. As you can see here, proton pump inhibitors are associated in causing osteoporosis also. All right. So everything should be taken and within the normal limits, and like it should not be consumed for a long-term basis. Now, secondly, secondary to the medical conditions, osteoporosis could also occur. For example, hypercortisolism. Can you tell me a condition in which there is hypercortisolism? A condition in which there is hypercortisolism? Okay, definitely I'll use the thick marker in the next class, okay? Exactly. So, Dr. Gurjeet, you have answered it correctly. That is Cushing syndrome. So, there occurs hypercortisolism there. All right. Now, I hope you know this concept of cortisol here. Let me explain to you here itself. So, from where is cortisol coming? Can anyone tell? From where is cortisol coming? Yes. Excellent. So, the answer is adrenal. So, this is the kidney. What's sitting over the kidney is the suprarenal gland or the adrenal gland. Adrenal gland. Now you divide adrenal gland into two subparts, adrenal medulla and the adrenal cortex. Adrenal medulla and adrenal cortex. Can anyone tell me what is being produced in adrenal medulla? What is being produced in adrenal medulla? Yes, exactly. So the answer is catecholamines. Catecholamines are being produced, for example, epinephrine or epinephrine, they are being produced in the adrenal medulla. Second question, which cells produce catecholamines in the adrenal medulla? Which cells? Your answer is going to be chromaffin cells. Chromaffin cells. Third question, what stimulates the adrenal medulla to produce catecholamines? What stimulates the adrenal medulla to produce catecholamines? The answer is yes, acetylcholine. Exactly. So acetylcholine stimulates the adrenal medulla to produce the catecholamines. Second implied concept here. Can anyone tell me the tumor of adrenal medulla in which there is excessive release of catecholamines? Yes? Tumor of adrenal medulla? Exactly. So the tumor of adrenal medulla is adrenal medulla, that is pheochromocytoma. That is pheochromocytoma. Alright. Now when you talk about the adrenal cortex is further divided. Can you tell me what is the mnemonic that we usually learn? That is GFR. GFR. Okay. G for zona glomerulosa. F for zona fasciculata. Zona fasciculata. And R for zona reticularis. Zona reticularis. So what is being produced in zona glomerulosa? Your answer is aldosterone, the mineralocorticoid aldosterone. Okay. What is being produced in zona fasciculata? Your answer is cortisol. What is being produced in zona reticularis? Your answer is going to be androgens. Androgens. Okay. Second question. What stimulates the zona glomerulosa to produce aldosterone? Anyone? What stimulates the zona glomerulosa to produce the aldosterone? Your answer here is going to be angiotensin 2. Angiotensin 2. Now guys, let me see who can answer this. From where is angiotensin 2 coming? Yes, exactly. Once the RAS, the renin aldosterone angiotensin system gets activated, there is going to be formation of angiotensin 2 from angiotensin 1. And this conversion of angiotensin 1 into angiotensin 2 occurs with the help of which enzyme? Which enzyme? Yes, angiotensin 1 converting, yeah, exactly. The answer here is ACE, angiotensin converting enzyme. Alright. And what stimulates the zona fasciculata and reticularis to produce cortisol and androgens respectively? Who is stimulating fasciculata and reticularis? Yes? Exactly. Here the answer is going to be ACTH. Alright. Here the answer is going to be ACTH. Okay guys, from where is ACTH coming? From where is ACTH coming? Anyone? Yes, Samkit, you tell me from where is ACTH coming? Mansi? Okay. Which pituitary? Exactly, anterior pituitary. Okay. Another homework is to know the anterior and the posterior pituitary hormones. Okay, there are different hormones that are being stored and released by the pituitary. For example, the anterior pituitary we have LH, FSH, growth hormone, ACTH, prolactin, TSH. When secondly, posterior pituitary, what are the hormones being stored and released by posterior pituitary? Which hormones? Posterior pituitary. Your answer is going to be ADH and oxytocin. Exactly. So the posterior pituitary hormones are ADH and oxytocin, and the anterior pituitary hormones are ACTH, TSH, LH, FSH, growth hormone, prolactin. All right. Another question. What is the relationship between dopamine and prolactin? What is the relationship between dopamine and prolactin? Can anyone tell? Exactly, inverse relationship. That means dopamine inhibits the release of prolactin. Keep this point in mind. All right. Now, coming back, hyperthyroidism, hyperparathyroidism. These are just the examples of the conditions that could induce the secondary osteoporosis. Okay. Now moving on to the main topic. Now, supposing someone is having osteoporosis. Usually, these type of patients they don't get to know about osteoporosis because it is usually asymptomatic in the beginning. But how could a patient come to you and you could suspect osteoporosis? Clinically, what would you expect in a patient to be in case of osteoporosis? Yes. Clinically, what are you expecting in a patient who is having osteoporosis? Exactly. So there are fragility fractures. All right. So usually these type of patients they come to the ortho OPD and these have fractures. So fragility fractures means the fracture that is being induced with very minor trauma. The bones become so weak that even by sneezing or laughing or coughing or just fall from a standing height, these patients could get the fractures. Okay, this is the condition of bones in osteoporosis. Now, what happens? What is the most common location of fractures in case of osteoporosis? This is very, very important. The answer is number one. The vertebral fractures are the most common. Okay, so the vertebra are most commonly affected. There would be vertebral fractures. Secondly, fracture neck femur. All right, fracture neck femur. Third, fracture distal radius, that is Colles fracture. And after that, the other long bones. All right. So just remember the high yield point here is number one vertebral fracture, number two neck femur, third is distal radius. Moving on to the next point. How would you like to diagnose a case of suspected osteoporosis? So what you would be ordering? Okay. So lab tests include you will order serum calcium levels, vitamin D levels. Okay. Now the peculiarity of osteoporosis, supposing you are being given this as an arrow question. Okay. So let me write it down. Serum calcium, vitamin D, PTH, ALP. So are you expecting anything to be increased or decreased in case of osteoporosis? Yes. So what will happen to serum calcium levels? Exactly. So in most of the cases, you will find that the labs are normal. Labs are normal. So you're not going to rely on the labs to diagnose the osteoporosis. All right. So what you're going to do is you're going to do a DEXA scan, that is do an energy or X-ray absorptiometry scan. You're going to get the BMD, that is bone mineral density of the patient. Then this is being compared with the BMD of a young adult female reference mean, and that is the T-score. So this interpretation, guys, make a flashcard for this. This is very important. So supposing the question is mentioning a lot of things, and ultimately you come across this T-score. So immediately you're going to think about osteoporosis number one or osteopenia. Okay. So T-score, if it is less than or equal to minus 2.5, that is going to be osteoporosis. But if T-score is between minus 1 to minus 2.5, that is osteopenia. And I told you, number one, osteoporosis is associated with increased risk of fractures, whereas in osteopenia, the risk of fractures is not increased, but still the bone mineral density is reduced. The T-score more than or equal to minus 1, that is going to be normal. All right. So this is the interpretation that you have to learn in case of osteoporosis, the T-score. This is very, very important. Now moving on to the treatment part, guys. So how would you like to manage the osteoporosis? How would you like to treat the osteoporosis? So drug of choice. So coming back to the main question that was being asked, okay? The drug of choice for osteoporosis. The best initial drug that you would prefer for a patient who is diagnosed with osteoporosis would be bisphosphonates. Okay, bisphosphonates. Now, why do you prefer bisphosphonates and what are the names of bisphosphonates? So let us try to understand what bisphosphonates are going to do here. So we have group of drugs, class of drugs known as bisphosphonates. Can anyone give me the examples? Yes, exactly. Someone wrote zoledronate. So we have alendronate. Then we have zoledronic acid. Then we have ibadronate. All right. Risedronate. So there are many bisphosphonates. These are the main names. Now, why do you prefer bisphosphonates as the initial drugs for or the first line treatment for osteoporosis? The reason is that bisphosphonates they inhibit the osteoclast. They inhibit the osteoclasts. So that means if bisphosphonates are inhibiting the osteoclast, right? So what is going to happen? They are going to inhibit the bone resorption. They are going to inhibit the bone resorption and ultimately they are going to save the bones. Okay, so this point is really important. They inhibit the osteoclasts and ultimately they inhibit the bone resorption. Now moving on to the next point here. What are the side effects? So INICTs, if you see the previous years, okay, this side effect is very, very important. Osteonecrosis of the jaw. If you look at this picture, you can see the exposed maxillofacial bones here. Okay, so this is osteonecrosis of jaw. So if someone is taking bisphosphonates for a long period of time, this could happen. Along with that, there could also be the occurrence of atypical fractures, atypical femoral fractures in case of bisphosphonate therapy. Atypical femoral fractures. So this is also another side effect. Then esophagitis. Esophagitis means inflammation of the esophagus. Okay. So pill-induced esophagitis. So you can make a flashcard. This is also your homework to learn the drugs that could lead to pill-induced esophagitis or drug-induced esophagitis. Okay. One of the drug, I'll give you an example here. An antibiotic. An antibiotic that could lead to pill-induced esophagitis. What are those? Which antibiotic? Exactly, tetracyclines. Tetracyclines could also lead to pill-induced esophagitis. Okay. Now, this is very important point. Supposing you are about to prescribe bisphosphonates to a patient. So, what advice would you like to give to a patient before prescribing it? Would you ask the patient, would you tell the patient something before giving bisphosphonates? Anyone? Would you be asking the patient something? Exactly. So number one, you're gonna ask the patient to stay upright, for at least 30 minutes. You're gonna ask the patient to stay upright for at least 30 minutes. That means you're gonna tell the patient, do not lie down immediately after taking this pill. Okay? What is the reason? What is the reason? If someone is consuming the pill and immediately after taking the pill, the patient is lying down, so there are chances of reflux. There are chances of reflux, and ultimately this will irritate the mucosal lining of the esophagus, leading to esophagitis. Okay, there could be ulcerations. Remember this. So always ask the patient not to lie down immediately after taking this drug, or you can ask him to stay upright for at least 30 minutes and take it with plenty of water. Take it with plenty of water. All right. Similarly, there is one, let me tell you one scenario here. A young female comes to you. She is having pallor, koilonychia. She is having pallor, koilonychia. Now, when you look at the, you order some tests, you order the iron studies. Along with that, MCV. MCV is around 70. Hemoglobin is 9. Okay. And iron studies shows reduced serum iron. So what is this? What are we talking about here? We are talking about iron deficiency anemia. Iron deficiency anemia. What type of anemia is iron deficiency anemia? Microcytic hypochromic. Okay, microcytic hypochromic. I hope you know that anemias are actually being divided most commonly on the basis of MCV. Okay, so MCV, you divide it, make 3 arrows under it. So MCV number 1 less than 80, 80 to 100, then more than 100. If MCV is less than 80, you call it microcytic. The size of the RBCs is small. 80 to 100 is normocytic. And more than 100 is macrocytic. Macrocytic. And iron deficiency anemia is microcytic hypochromic. Okay. Now you come across this patient who is having iron deficiency anemia, guys. You start the iron supplementation. Would you advise the patient something before giving the iron supplement? Would you be advising the patient about something? Anyone? Exactly, Samkit. That is the correct answer. Number 1, you will ask the patient not to take iron tablets with milk or tea. Okay, not to take the iron tablets with milk or tea. Secondly, you will ask the patient to take the iron tablet with lemon water, with lemonade, or you can prescribe vitamin C supplementation. What is the reason? Why do you ask the patient to take it with lemonade, or why do you prescribe vitamin C supplementation? Yes? The reason is that vitamin C increases the absorption of iron. It increases the absorption of iron. Alright. So there are a few drugs that you always advise something before prescribing them. Similarly, guys, we have another case. For example, the patient comes to the derma OPD. The patient comes to the dermatology OPD and the patient tells you, doctor, I have a painful lesion on the genitals. When you examine, you find that there are grouped vesicles with a red base, grouped vesicles with a red base. Okay, what are you expecting this to be? What are you expecting it to be? Exactly. Okay, so here we are talking about the HSV, herpes simplex virus infection. So here we are talking about exactly the genital herpes. Genital herpes. Alright. Now, what is the drug of choice for herpes infection? Can anyone tell? The drug of choice for herpes infection? Exactly. The drug of choice is acyclovir. Okay. Now, what you have to advise the patient before prescribing acyclovir? You will ask the patient to maintain adequate hydration. Exactly, Samkit, you gave the correct answer. Why do you ask the patient to maintain hydration properly? The doctor will always tell you, okay, consume plenty of water. Do not, there should not be dehydration. The reason is that acyclovir is prone to cause crystal-induced nephropathy. It could lead to renal stones. So, to prevent the crystal-induced nephropathy, hydration is must. To prevent the crystal-induced nephropathy, hydration is must. All right. So keep this point in mind. Now coming back to our main topic. So another thing that happens once someone starts consuming bisphosphonates is that serum calcium levels, they decrease. Now what is the reason? Why serum calcium levels decrease? What is the reason? Anyone? Now what did we discuss? Bisphosphonates, they inhibit the osteoclast. So if they are inhibiting the osteoclast, they are inhibiting the bone resorption. They are inhibiting the bone resorption. So if they are inhibiting the bone resorption, that means the calcium which was previously coming from the bone into the blood is no longer going to happen because bone resorption is inhibited. Okay, so the serum calcium levels, they are going to be reduced if someone is taking bisphosphonates for a long time. Okay, that means it will induce hypocalcemia. It is going to induce the hypocalcemia. So keep this point in mind that what happens to the serum calcium levels if someone is consuming bisphosphonates, your answer is going to be hypocalcemia. All right. So what would be the signs and symptoms of hypocalcemia? What would be the signs and symptoms of hypocalcemia? Number one, tetany. Any other sign and symptom of hypocalcemia? Yes. Muscle spasms. Muscle spasms. Then paresthesias. Paresthesias. And then there could be constipation or there could be risk of cardiac arrhythmias. Risk of cardiac arrhythmias. All right. Now one question here. Who regulates the serum calcium levels? Who regulates the serum calcium levels? What is the answer? Who regulates the serum calcium levels? Your answer is yes, PTH, parathyroid hormone. Parathyroid hormone. So guys, supposing serum calcium is reduced, what will happen to PTH levels? What will happen to PTH levels if serum calcium is reduced? Increase or decrease? Your answer is going to be increased. PTH will increase if serum calcium levels are decreased. Similarly, if calcium levels are increased, PTH will decrease. Another question, how do you think PTH maintains the serum calcium levels? How it does so? This is also very important that you know the role of PTH. Okay, so what PTH is doing, number one, PTH upregulates or increases the expression of an enzyme that helps in the formation of active form of vitamin D. Which enzyme is that? An enzyme responsible for the conversion of calcidiol into calcitriol. Which enzyme is that? Your answer is 1-alpha hydroxylase. 1-alpha hydroxylase. Okay, so 1-alpha hydroxylase is an enzyme that converts calcidiol into calcitriol. Calcidiol is 25-hydroxy vitamin D. Calcitriol is 125 dihydroxy vitamin D3. Okay, the active form is calcitriol. Now guys, you tell me what is the action of vitamin D? What is the action of vitamin D? Can anyone tell? Remember, vitamin D increases the absorption of calcium as well as phosphate from the gut. That means it is increasing the absorption of calcium as well as phosphate, and hence increasing the levels of serum calcium, hence increasing the levels of serum phosphate also. Okay, so PTH, by increasing the expression of 1-alpha hydroxylase, it is helping in the more formation of active form of vitamin D, that is calcitriol. And if more active vitamin D is there, more absorption of calcium will be there from the gut, and the serum calcium levels are going to increase. Now the next question is, from where is this 1-alpha hydroxylase coming? Where do you see the activity of 1-alpha hydroxylase normally? Can anyone tell? 1-alpha hydroxylase activity is present in the cells of PCT. PCT is proximal convoluted tubule, that is part of the nephron. Okay, so cells of PCT express 1-alpha hydroxylase, and 1-alpha hydroxylase leads to the conversion of calcidiol to calcitriol, and hence more active vitamin D, more absorption of calcium from the gut, and serum calcium levels increase. Second question. The second reason how PTH regulates the serum calcium levels. What is that? Yes. So the second thing that you have to keep in mind is PTH increases the PTH increases the expression, or it upregulates rank ligand. So what did I tell you about it? The more the rank ligand and rank interaction, rank ligand is on osteoblast, and rank is on classed. The more the interaction between these two, more will be the activation of osteoclast. Okay, the more the activation of osteoclast, what will happen? Osteoclast will start to eat away the bone. They will start to eat away the bone, and the calcium from the bone will now start to come in the blood. Okay, so serum calcium levels, they are going to increase. So that is how PTH is influencing this. All right, so keep this point in mind. So you should know how PTH is actually maintaining the serum calcium levels. Now coming back, we were discussing about osteoporosis. From osteoporosis, we discussed a lot of other important points as well. So whatever term or whatever condition you come across while reading a topic, always read about that in between that particular topic itself, where it is making sense. So you have to make connections between two pathologies, or you have to make connections. That is how your brain would be able to connect things and understand it. Okay. Now, the other drugs that are being preferred for osteoporosis, they are denosumab. Now, anything that ends with the mab, that is monoclonal antibody. Okay. So, denosumab is what? Denosumab is the monoclonal antibody against the rank ligand. So, now what happens is they say that denosumab works like osteoprotegerine. What did I tell you in the beginning about osteoprotegerine? Osteoprotegerine was being secreted by the osteoblast, and it was inhibiting the interaction between the rank ligand and the rank. So overactivation of osteoclast was not taking place. Here what is happening? Denosumab is working against the rank ligand. So if it is working against the rank ligand, what is going to happen? Rank and the rank ligand interaction, this is going to be inhibited. So ultimately, what is being inhibited? The osteoclastic activation. So what is being inhibited? Osteoclast activation. And ultimately bone resorption is going to be inhibited. All right. So that is the mechanism of action of denosumab. That is a monoclonal antibody against the rank ligand. So this was also being asked in one of the INICT. Okay. So this is important. Moving on, then we have calcitonin sprays also. In OPDs, calcitonin sprays are also being prescribed. Okay, we usually say that do not spray calcitonin for more than 6 months. The reason is that they are cancer inducing. Okay, they could induce the cancer. They could lead to cancer. So not the use should not be more than 6 months. All right. So this completes the important points regarding osteoporosis. Please know this. All right. Now, tomorrow, day after tomorrow, I'll be updating this schedule, and I'll be coming back with the more interactive session. This was the first session. So I wanted to, give you a brief overview that how we are going to study for the next month. All right. So I'm going to integrate all the important concepts all together so that so that you won't even feel bored while studying. So during one particular topic also, I'm going to teach you a lot of things. All right. So whatever things I told you to read at home, please do so. And I'll see you guys tomorrow. And Unacademy is offering a lot of discounts on the iconic subscription. Okay. So you can see these plans and you can use my code. I'm writing that code here to get the discounts in case you want to subscribe it. That is Insta10. So if you want to subscribe to Unacademy, you can use the code Insta10. All right. So I hope you liked today's session. I would be coming back tomorrow with more concepts. Please drop your feedback and I'll see you tomorrow. Bye-bye. Yes, I can see your comments. Bye-bye.